Fluid and Electrolytes IV unit for Introduction to Nursing Concepts. This is Martha Olson from Iowa Lakes Community College. This is part 5. As we look at IV fluids, we know there are different classifications. Osmolarity describes the tonicity, the concentration of a solute within that, how many particles are in there. Osmolality is the osmotic pull that those particles have in that unit of water. And it's influenced by the quantity, how much is dissolved in there, and the extent that the pull has. It's kind of like when you're going to go gargle with salt water because you have a sore throat. If you add just a little bit of salt into a lot of water, it doesn't have much osmolality. But when you add a little bit of water and a lot of salt to gargle with, you know that it has a lot more particles per unit of water, per milliliters of water. When we compare and contrast the two, because they sound very close, we see that osmolality is a number of osmoles in that unit of kilogram in that solvent or that fluid. It's the concentration of particles in that, and we look at that with things like diabetes shock and dehydration. Osmolarity, on the other hand, is in 1 liter of fluid. It's the concentration of the solution, and we look at the particles in that. When we look at crystalloids and colloids, those are different types of infusions. Crystalloids are the things that we hang, the IV, the lactated ringers. Colloids are the blood is the most common colloid that we hang. But other ones are hetastarch, dextran, plasma protein solutions. Crystalloids are a lot more convenient because they have a longer shelf life, they're easy to store, they don't cost as much money, and they can be stored at room temp, whereas our colloids or our blood products, our blood transfusions, have to be kept refrigerated. They're very expensive. We have to make sure we type and cross to make sure that the patient will not have a reaction to it. And because it has such a short shelf life and it has to be kept cool, they're much more expensive. You oftentimes will see crystalloids being ordered and administered. The colloids are safe for the patient that's had a huge hemorrhage and we need to replace back some of the blood and albumin and protein products that they do need. So our crystalloids will crystallize or form crystals. They diffuse very well through membranes, and they are usually our electrolyte solutions that we will be talking about being either isotonic, hypotonic, or hypertonic. On the other hand, our colloids are the albumin, dextran, plasminate, and hetastarch or artificial blood that do not dissolve easily. They remain in the blood vessels, and so they help control or help establish a blood pressure for somebody that has hemorrhaged. When we look at our crystalloids, and the 3 different types are isotonic, hypotonic, and hypertonic, and they all serve a different purpose. Isotonic is the same as what we have in there already. Very commonly hung. There's no effect on shrinking or expanding the cell size, so we simply give isotonic fluids to expand the blood volume. The most common are lactated ringers, LR, and normal saline, or your 0.9 sodium chloride. I was always told in nursing school that if you have a patient that's hemorrhaging and you don't have an order for an IV, but you know you need to get fluids in them, hang an isotonic, because they're the most safe for you to hang until you get an order from a physician. With the hypotonic, they shift the fluid out of the blood vessels and into the cells, and our concern is that they will swell and cause damage to the cell if we aren't careful in what we're doing. Our examples are 0.5 or half sodium chloride, half strength saline. Dextrose 2.5 is also considered a hypotonic. The advantage of a hypotonic, again, is it shifts into the cell, providing fluid into the cell if it's needed at that point. They can hydrate cells, but they can pull too much fluid from the circulatory system, from the blood vessels, and deplete our circulation and our blood pressure and cause problems with perfusion. Hypotonic is used mostly for diabetic ketoacidosis or maintenance therapy. Hypertonic causes the cells to shrink, so water is pulled from the cells and pulled back into that intravascular space from the cell. The examples listed here How I remember them is most of these are dextrose containing, and sugar makes kids hyper, and so your hypertonic solution is a D5W 0.45%, or what we'd call a D5 and half, because 0.45 is considered half. D5.9, D5 lactated ringers, those are all types of hypertonic solutions. The advantage is that they can help raise the osmotic pressure in the extracellular fluid, and fluid then can shift into where we need it. You do have to watch your blood pressure, your lung sounds, and sodium levels, and fluid overload is always a concern with a hypertonic solution. They can be used for a patient in shock because we pull the fluid into the vessels where they're needed, or within a patient with hyponatremia. Again, we have to use very cautiously in our patients with respiratory issues such as pulmonary edema and congestive heart failure. When a solution contains dextrose, it's great because it gives a little bit of calories and nutrition, not a lot, but it does help for a patient that's perhaps NPO for a short period of time. It replaces some lost fluids to help treat dehydration and reduces the protein breakdown of glucose for that negative nitrogen balance. The dextrose can be very irritating for the vein, and no potassium may cause hypokalemia, and so we can see then that we need to keep watching our potassium levels because your dextrose solutions are deficient in potassium, and we can get into a hypokalemia situation fairly easily. Your sodium chloride solutions are used with your blood transfusions. Important to know, only 0.9 sodium chloride or full-strength saline is used when we give a blood transfusion. The disadvantage is we can get too much sodium and have a hypernatremia situation and a loss of the potassium or hypokalemia. Circulatory overload is important, so watch your lung sounds and edema and make sure that you're monitoring your patient closely. Anytime we add potassium to an IV, it has to be mixed in a 1,000 milliliter bag or in a solution. We cannot give potassium IV push undiluted because it will kill the patient. It is very potent. We always want to run our potassium on a pump, and all of your potassium is mixed in the pharmacy, so there is no mix-up with a syringe with potassium in it getting mixed up as a saline flush and giving it that way. We want to always monitor your heart, your EKG, and your potassium levels. And a patient that comes in hypokalemia, we will oftentimes do like a 5-hour potassium replacement and then get a potassium level after that is done. But we administer it very slowly and always diluted in something else. TPN is also part of this unit. When we look at TPN, or total parenteral nutrition, it's also called hyperalimentation or hyperal. It gives calories and it gives electrolytes and nutrients back to the patient based on what they need. This is for the patient that is very ill. The patient is going to be NPO or have a non-functioning GI tract for quite some time. It's very expensive, and they have to have an established IV, not a peripheral like what we're putting in, but either a PICC line or a central line to be able to administer TPN. It's mixed every day by the pharmacist based on lab values, patient weight, patient assessment, and it's very closely monitored. So when we hang total parenteral nutrition, it bears close watching. It gives the characteristics in nutrition of the proteins, carbs, fats, and electrolytes that the patient needs, and we would then use it on patients that are listed here. Your severely burnt patient, anybody with cancer, malnutrition, a peritonitis, very severely ill clients need more protein and nutrition, and if they're not eating and maintaining their weight and health, we have ways, and TPN is one way to do that. Again, make sure you have a central line or a PICC line, not a peripheral, not one that we would start on the floor, but your specific higher maintenance IV lines will be used for TPN. The advantage is that it helps repair tissue. We specifically make it for what the patient needs. There are disadvantages such as infections, pneumothorax, hemothorax, and then we have to wean the patient from TPN. It's like being on a big, fat, high-calorie diet for a long period of time, and you can't just suddenly go on a diet and eat carrots the next day because your body needs time to adjust. And it's the same with TPN. When you get the order that the patient is going to start eating nutrition and we need to wean them off, we will probably take them down 25 to 50% and see how they tolerate it, continue to watch blood sugars, watch how they're tolerating it, and very slowly wean them from that TPN. So we begin the fusion slowly and wean them up, and as we take them off, we bring them down slowly and wean them off of it. We check blood sugars every 6 hours, not according to meal times, because TPN is their meal that's running 24 hours a day. So the TPN blood sugars are done 612 and 612 or 3939. We get very accurate I&O, very accurate weights. We want to make sure that we are watching that patient output very closely so that we can see, is this TPN working? Is it enough, or do we need to alter it to help them heal and get what they need? As far as blood and blood products, we're going to do blood transfusions, and in this class just mostly look at what is a blood transfusion and who might need one. The blood is obtained from the lab after they have come to type and cross the patient to make sure that that blood is what they need. We always have to have a physician's order. Sometimes your physician will order a unit of Lasix or 20 to 40 milligrams of Lasix IV in between units if we're worried about congestive heart failure and too much fluid on the person. That blood has got to be administered within 4 hours because it's protein. It will grow bacteria, so we have time limits to be able to get that in. It uses the special Y administration tubing that has the filter, and we want to hang it with normal saline, prime the tubing. Then when the patient is all set and ready to go, they've signed their consent, we know the blood is typed and crossed, and we've double checked it with another nurse, we will then start administering the blood. We stay with the patient for the first 20 minutes or per protocol to make sure that they are not going to have a reaction, transfusion reaction to that, and we would need to stop that blood and do all the rescue things we need to do with that. We educate the client as to why they need the blood. We need to make sure that our IV site is an 18 or 16 because it will run too slowly through a 20. It's too small because blood is thick. We need to make sure that they understand what they're watching for. If they start having a thick tongue, shortness of breath, back pain, flank pain, wheezing, no urine output or oliguria would be things that indicate to us that they are not tolerating that blood transfusion, and we need to stop it and call the physician. Our nursing responsibilities are to make sure that the patient is aware, have the consent signed, have your baseline vital signs, including the temperature, to make sure they aren't febrile before the transfusion stops, and then have that IV that's very good so that it doesn't infiltrate in the middle of the blood transfusion, and that stops our process. Make sure when we're giving the blood transfusion, we verify with another nurse. We connect the blood tubing and shut off the saline, get the blood infusing, and then stay with the patient. If they have a reaction, we want to make sure we stop that in transfusion, but do not throw it away. Do not take the IV out. Simply unhook it at the site where the IV is going into the patient and run just 0.9 normal saline in at that time to maintain your IV, maintain your blood pressure. Call the doctor, get the blood bank, stay with the patient and monitor vital signs and airway, and then follow your policy as far as making out an incident report, collecting a UA to be sent down, and document that all of the things that you did when that reaction happened. Other sites that we have are listed here. Intraosseous is into the bone. These are only used in very specific considerations or critical patients. We won't spend any time looking at them in this class. We want to think about the older adult and some of the things that happen to them that we need to be considerate of. Watch that we aren't giving them fluid overload. They have congestive heart failure. Their decreased renal function can impact fluid overload very easily. As far as using a tourniquet, sometimes the blood pressure cuff is more effective because a tourniquet cuts into the skin and is not very comfortable for them. As far as legally speaking, we know that we have got to do things correctly with that IV because it is a very serious complication when things don't go as selected. Follow your scope of practice, know your drugs, monitor and assess your patient for any complications we have, and then follow up with your evaluation and documentation. This ends our unit on IV therapy. Thank you.